Hey, folks, if you haven't done so already, please click that subscribe button below. That'll help us grow as a show, attract better guests. Together, let's make healthcare better for everyone. Once again, click that subscribe button. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Kober. I am your host, and we are joined today by Dan LaBroad of Ovation out of the great state of Texas. Welcome to the big show, Dan.
Thanks for having me on, Ray. This is awesome.
Oh, of course, man. So did I get it right? Is it Ovation Benefits or Ovation, or what's the name of your company?
Yeah, Ovation Health and Life Services. So, or ovationlife.com.
It's very complicated, Dan.
Yeah,
Ovationlife.com. Doesn't get much easier than that.
Yeah.
So Dan and I go way back, folks. We are part of the same mastermind group together, Next Gen, which is, I believe, how our paths first crossed. And the idea behind Next Gen is it's a group. It's a group of like-minded agents and advisors, benefits brokers who got kind of tired of pushing the wares of the insurance carriers, and the group really was born out of a place of frustration where the folks that we're aligned with got tired of taking the same old back to our clients every year when it came time for renewal, and presenting them with the traditional spreadsheet of one worse option after the next. And why? Because typically our clients were faced with double-digit increases. And you could correct me if I'm wrong, Dan, but I think we both kind of probably joined Next Gen because we were tired of that and looking for a better way to serve our clients.
Yeah, I think the clients are tired of seeing, like you said, double-digit increases each year. And at a time where no one knew any better. We didn't know better. The clients didn't know better. And really, the insurance carriers had everybody kind of the wool pulled over their eyes that this is just the way it is. And then, a group of us have all gotten together, and now we're realizing there's a better way to do things. And now we're just trying to take that to the masses.
Yeah, for sure. So tell us a little bit. No one raises their hand as a kid and says, "I want to be an insurance man when I grow up." Right? I don't think you were any different, and you didn't start out in Texas, but that's where you are now. Tell us a little bit about your humble beginnings.
Well, yeah, so I started back in Massachusetts. I went to school in University of Tulsa, which brought me to Oklahoma, and then that transferred me into Texas, and I've never been there ever since. So 25 years.
Wow.
But no one ever wants to go into insurance or plan, and I certainly didn't. I had worked for a financial company, and just because we talked about, I didn't personally do it, but people in our industry talked about life insurance and things like that, we had to have an insurance license. And so when I left that company, I was like, what am I going to do? What do I do with this license? And that's like many people. I started in the supplemental area with Aflac and became a top producer there. And then my clients started asking me to do more for them. Can you do our health insurance? Can you do dental, vision, and so on? And that's really where it started. And that was, 16, 18 years ago. But there have been multiple paradigm shifts over my career where, again, it was very simple: spreadsheeting, giving one worse option after the other, and switching carriers each year to save a few dollars. And then when the ACA passed, I started really looking at level funding and there was really only one or two carriers that did it on the smaller group side. But I started embracing that and teaching that to clients, and we had a lot of traction with it. But it was still a tough sell to employers, is getting them to understand what this different animal was. Now you fast forward, and I'd say 6 or 8 years ago, when I joined the mastermind and really started focusing on self-funding, all sorts of self-funding, captives, level funded, fully unbundled, transparent self-funding, taking these to the clients. And now they're way more receptive. And it's actually a much easier conversation now because they're hearing about it and they're looking at the renewals and seeing, I just had one today email me 40%. They're like, I need help.
40%. My God. Yeah, it's crazy. It's funny how your career trajectory and mine kind of paralleled. My initiation to insurance was Aflac back in 2001. So I've been doing this more than a minute, but I have a very similar story in that my clients kind of came to me out of frustration and said, can you help me with more than just Aflac? Because they were under so much pressure from these crazy renewals that they were getting. And so one thing led to another. And, I personally didn't feel like what could little old me do up against the Marshes and the Aons of the world, right? These are mega brokers with skyscrapers in Manhattan. I'm a New York City kid, and you're talking about multi-billion-dollar entities. And so I never really dreamed of competing in the space until I got involved. And, my path, kind of crossed with Nelson Griswold, who's the leader of the mastermind group, NextGen, at a voluntary benefits expo in Atlantic City, New Jersey. I heard him kind of preaching the gospel from stage, as Nelson does. And, I interviewed Nelson as well. And I thought his dad was a preacher, but his son is a preacher. But I think his son gets it from Nelson. Because Nelson was preaching the gospel and I was coming to Jesus, because what he was saying was just, how backwards the system is and how corrupt it is and how insurance carriers are not your friends and they're making money hand over fist, and there is a better way to serve your clients than just doing the same old status quo stuff. And I really did kind of have a come to Jesus moment. I chased him down and I said, we got to get together. And one thing, led to another, and it led to me joining the mastermind. And since then, it's been a wild ride. But I want to back up for a second, because I don't know that I agree 100% with you. Maybe you're doing something right that I'm not. I still find that employers are resistant to anything new. First and foremost, the conversations that I like to have are with the C-suite. I want to talk to CFOs primarily, or CEOs if possible. Of course, I'll talk to anyone who's in leadership, including HR, as long as they're receptive to a new idea or a concept. But one of the hardest things I find in my history of sales is getting people to change their mindset about breaking away from a traditional insurance carrier. And look, Dan, I've kind of learned a lot of lessons over the years, and I never go in kind of saying, this is what you have to do. That's not my job. My job is to kind of lay out the good, the bad, and the ugly, and hopefully lead them down a path of education and enlightenment, so that, and hopefully if I do my job well, they're kind of telling me that they want to do some of the more creative things that we could do. But it is a process, and I wish it were easier. Maybe I'm doing something wrong, but I find that it's a little bit of an uphill battle.
Yeah, I think, you said it's a process. I think every conversation has to start with, first of all, what is wrong with what you have now? And being really blunt, I'm very blunt about it, is here's where I see the gaps, the overspend, the profit leak in your plan. And you need to address that. But we talk about the crawl, walk, and run. And so where are you now? Okay, you're crawling, you're with a Blue Cross, you're with United. Let's get you into something level funded. We explain the pieces of the plan, and I'll say, your current plan has exactly the same pieces we're talking about. It's got a network, and it's got a administrator, and it's got a PBM. The difference on your fully insured is they're all working together to make money off of you. And all we're doing is taking those same pieces, putting in better partners that are there to, sitting at the table with you to make your plan better, reduce your costs, and give your employees better care. And when we start breaking it down like that, they actually understand it. And we start talking about the overspend in the pharmacy, how they're overpaying 40% of their drugs minimum. One thing I bring up too is that the carrier doesn't provide any health care to them. They think that Blue Cross is providing their health care. And I say, no, the doctors are providing the care. They're just determining how much they're paying for it. And so when you start realizing, well, these aren't my doctors. I'm not losing doctors. I'm not changing doctors. We're just changing how the payments are happening. And we're getting more cost controls, transparency. And then with that transparency, we can help the employees more with their care. And then we talk about a lot of the advocacy things we do to, again, further reduce costs, but give better care. So we really started explaining it in that conversation where it's not just about money, but it's about taking care of your employees. They really open up and get receptive. And the good thing, one thing I always use, and it works really well for me, I said, you know what, you're with Blue Cross, you're with United Healthcare. The good thing is you're already in your worst case scenario. I can only bring you up from there. I said, so if it doesn't work out, you stay where you are and you know what you're getting. And that really opens them up, going, oh yeah, I guess I can only do better.
100%. And that's so true because they truly are in their worst case scenario at that point, whether they believe it or not. I think they're resistant. And the word that I use is a 4-letter word that starts with F. And that word is fear, right? So they're afraid of the unknown. And all that they know is their health insurance ID card with that logo, whether it's Cigna or United or Aetna or any one of the bigs, that gives them a certain level of comfort and peace of mind. They really don't understand, though, that what that means essentially, more often than not, is that they're paying the absolute most that they can for healthcare.
Yeah, and I think we have that conversation about the card, and I'll pull a card out and say, "Look at your card right now. Your TPA is the carrier, your network is the carrier, your PBM is owned by the carrier. So now we're going to take that apart. We're going to have the same three positions or same three logos on the card, but they're going to be different ones. And they're going to be there for your vested interests and to make your plan better." And when you start showing that to them, and then even show them the transparency, we'll pull up some of the claims details we have on an ongoing monthly, real-time basis, showing, hey, look at last month. You just had 13 new people come on with GLP-1s. Why? We need to figure out what's going on with that. How can we reduce that? That's $13,000 it's costing you a month. And, your carrier is not going to do anything about it because they're making money off that. So what do we want to do? We want to make sure they're getting the drugs at the right price, the right time, and that they actually need those drugs. When we start showing the data and being able to really have conversations about what the employees are saying, because most of these employers, they don't see anything till they get the renewal. 40%. Why? Oh, you had all these drugs all year. Well, I didn't know about that. Now you know, and now you can address it. You can manage it. Month in, 2 months in, you start seeing that data, and data's king.
Well, it's been an uphill battle, I think, for employers to get to. I mean, first and foremost, they're in the dark about the fact that they even have access to data. Many of them are. I think the more evolved, more astute business leaders out there are on this, and they have their data. And that's a little bit of a different subject that we could broach. But so many employers don't even get data, and they don't know that they're entitled to it, or they get data and they really don't know how to interpret it. And so when you look at this, in a fully insured plan, it really is nothing more than a funding mechanism. And why is it a terrible way well, let me ask you, why is a fully insured plan a terrible way to fund a health plan?
Well, I mean, it's just, think about the IRS. If you're paying your taxes, you get so excited about a refund at the end of the year. Well, what do? You took a bunch of money out of your paycheck and gave it to somebody else to hold. And the only difference in a fully insured is you're giving that same money to them, but they're not giving anything back.
Correct.
Yeah.
So
Go ahead.
you're essentially managing this expense, which is often your top expense, second only to payroll, in the rearview mirror, right? You're presented with a renewal after all of the claims have been paid. There's no opportunity or mechanism for you to control claims. And so the only thing that you're left to manage is, well, what is my best case renewal scenario based on the claims that I had back there? And you just can't do that, right? You have to manage claims prospectively.
Well, I use an example. I was on stage at some conference and I was on a panel, and I talked about one thing too. When you're fully insured, you get a renewal. They're doing two things. They're looking backwards. They're saying, how much money did we lose last year? Or how much money did we make? And they say, oh, I had 18%. We're going to go down to 2. Well, because they probably made a lot of money off you. Or hey, your claims last year were crap, and now we're going to go ahead and give you this 30% increase, and you're stuck with it. Well, you had some bad claims last year. Now they're trying to recoup money from you. And maybe those conditions are gone. Maybe the person's left. They're not even there anymore, but you can't do anything about it. In our case, we say we're really looking forward. The past has already happened. We're on a 12-month stop loss contract. When that ends, it ends. What we care about is a forward in the front, looking through the front windshield, is what's coming up next year and the year after. How do we plan for that? How do we budget for it? And let's really have a roadmap of where we're going. And I use the example. I said, how many people get in their car and they use Waze or they use Google Maps? And why do you do that? You do it because you want to know where you're going, how fast you're going to get there. Are there accidents along the way? Are there things I need to worry about? You don't look at behind you. I said, that's what this is. We're creating this Google Maps or this Waze for the future to see where you're going. Are there going to be road bumps? What do we need to anticipate? And how do we manage that trip for the
Absolutely.
next 12 months?
Yeah, and so when you're in a fully insured plan, it really is kind of the worst case scenario for risk strategy because you're managing from behind, and so
Yeah.
it's just a terrible way to manage any expense, let alone one of your largest expenses. And
Yeah.
so going back to your example, in a self-funded plan, a custom plan where you have real-time access to data, and now a dozen people show up on your plan taking Ozempic, a GLP-1, what is the difference between I'm in a fully insured plan with Blue Cross Blue Shield, and that happens versus one of your alternative plan designs? What's the advantage to an employer in that scenario?
I think there's a few things. Let's just assume everybody on those drugs or any of these, especially your brand name drugs, they need it. It's just part of they have to have it. Well, the first thing we're doing is because we're using transparent fiduciary PBMs, we typically can lower the cost on those 20, 30, 40%. So you get immediate cost savings by putting, taking out the incentives that the PBMs have built in for the carriers right now. So we remove that, we reduce your costs. But we've seen a lot of the carriers just basically openly give it to them without any type of clinical rigor, without any looking into the actual conditions, because we know that they're making rebates on those drugs. They're making profit off of them. So when we see it now, we can say, look, we're going to see these drugs. We're going to make sure, first of all, are they type 2 diabetes or do they have the condition they need? We may ask for medical records to make sure they're getting the right drug. Do we need to go back into some type of step therapy? And we can see when they got it, how much they're paying. And it's really just being proactive on it, going to the employee and saying, all right, let's look at the medical records. We see doctors fudging medical records all the time right now.
Yeah.
They're pre-diabetes, pre-type 2, but they're really not type 2. And they haven't done any other maintenance drugs to manage diabetes. They really don't have it, but the way they word it, it flies right through the system. So we're really putting in those precautions and that transparency to be able to look at it and say, let's make sure if these drugs are needed, that we're paying the right price and that there aren't other options that are lower cost. But then let's make sure that they are needed. Let's make sure the employee's on the right drugs at the right price.
Yeah, I love that. There's been a lot of, I think, demonization, vilification of GLP-1 drugs like Ozempic and Wegovy. But to your point, it can be a real game changer for a lot of folks that have really kind of tried everything. Nothing is working, and they need assistance to drop that weight, to get into a healthy range, and put them on track. And so there's definitely a medicinal benefit and a huge positive for a whole mess of people out there, right? So we're not in the business of saying you can or you can't have the drug, but it's kind of a two-piece problem. And what I'm hearing you say is we're not just going to source this from one of the traditional PBMs, and we know that between OptumRx and Express Scripts and CVS Caremark, they control 80% of the drug marketplace. And they're also the biggest profit centers in those entities. And we're talking about entities that are very, very good
Mm-hmm.
at making money. And so just put your common sense cap on and say, well, their margin is our opportunity, because that's really what we're saying, to borrow a Jeff Bezos quote, right?
Yeah.
So that's number one. We're now sourcing the drugs a lot more effectively and efficiently for the plan. We're cutting out all the fat of that PBM middleman. And then the other piece of it is we also align with fiduciary PBMs that have a clinical side to them to make sure that the drug is clinically appropriate. And that's huge, because if the drug is not clinically appropriate, if someone is looking to lose 5 pounds, it's not a drug for them, right?
Mm-hmm.
And unless there's a real medical need that can, be exhibited, through their blood work or other findings, you're going to deny the drug to that person that wants to lose 5 pounds, because let's face it, if it's $1,000 a month drug, that's 12 grand a year. That's one member. Multiply that by a number of members, and now what you've created is an environment where your members are abusing the system, and everybody pays for that. And so I think a big part of what you do, Dan, is setting up systems to kind of catch that excess waste and bloat.
Yeah, and I think it's not just in the pharmacy side. When you look at what the billings are for surgeries, I'll give you an example. We just did a knee replacement surgery, and the hospital was going to bill out, I think it was about $68,000. Now Medicare pays out 16,000 for that same surgery. And so, we don't want to pay $68,000 out of the plan. And we were able to actually get the employee to Oklahoma Surgery Center, which is an amazing center, not too far from us. And we're paying 23,000 all in. That's completely bundled. So the employee now has no deductible, no co-insurance, no copay at a top level facility, and the employer's plan says $40,000. So again, that's that. Let's take the fat out of there. Let's make sure that we're getting the best care, but let's pay the right price for it. And employees, when they're incentivized to do that, they appreciate it, and they say, "Wow, yeah, I'm going to go Oklahoma City for a few days. I'm going to save myself, $8,000 in deductibles and co-insurance." So, and there's that kind of process in pretty much every aspect of the health insurance, whether it's virtual care, surgeries, doc visits, physical therapy. We know there's opportunities everywhere.
Yeah, no doubt. And I think armed with knowledge is power, right? So armed with that information, even the CEO would say, "Well, what are you, crazy? Why am I going to get this surgery here at, one of the big Dallas hospitals or one of the big Houston hospitals or one of the big San Antonio hospitals when I could hop on a quick flight and get the same surgery in a freestanding surgical clinic that has quality scores that are through the roof. It's the absolute best care that you're going to find anywhere. And at the end of the day, I'm not going to have any copay, any deductible, any coinsurance. My care is going to be free to me. And in many cases, employers will throw in lodging and round trip transportation because instead of paying, did you say what the cost of the surgery was elsewhere?
68,000 at the hospital and 24 at the surgery center.
Yeah. So look at that delta. You save the employee all of their traditional out of pocket medical expenses. You cover their transportation round trip,
Mhm.
and you're still way, way, way ahead of the game. The employee's happy, the organization benefits, everyone wins.
Well, yeah, and we've seen those facilities even when we were in the Caymans for one of the masterminds. We toured the facilities. These are top tier, high quality facilities. And you look at the cost savings of some of these surgeries, and you're like, how would you and your family like to go to the Caymans for 4 or 5 days?
Mm,
We'll pay for the trip, no deductible, because it's cheaper than getting it done at a hospital in Florida.
yeah.
And there's just great incentives out there. And it's interesting because a lot of the programs, whether it be physical therapy, labs, we have lab programs and imaging programs where if the employee goes to our advocacy and uses those, they have no cost, no out of pocket, and it reduces the cost of the health plan. So everybody wins. But it's funny, we sat an open enrollment meeting, we walked through all the services. You can get free brand name drugs if you do it this way. You can get free specialty drugs if you do it this way. You can free physical therapy. We went through all these services they get. And one employee spoke up and said, "This is unbelievable. I finally have a health plan I can use."
well, well, we're laughing, but it's true because what we've given them with the system that we have is that they have insurance, but they're functionally uninsured, right? If you have an employee that is just kind of scraping by, and they're a sole income provider, and they have multiple mouths to feed, and you give them a plan that first dollar coverage starts after they pay $3,000 deductible. That's useless to them.
Yeah.
It is the same as having no insurance at all. So yes, to your point, if now they have a plan where all they need to do is kind of follow the plan that's set, we don't need to make them experts. Just follow the yellow brick road. It's already there, right? Go to where you get your care. We're going to map this out for you, make it easy. And if you just, play along, you're going to end up with a $0 out of pocket experience. Most people will say, you're full of shit, Ray. You're full of shit, Dan.
Yeah.
That's too good to be true. You can't do that. What are you talking about?
Well, that's the words we get a lot of time. This is too good to be true. Even when we do our underwriting, we come back and we'll show. This year, I showed groups that in the fourth quarter, we had renewals, or we did new groups, level funded, self-funded on our platforms. And they were coming in 60, 70. I had one that was 150% under the BUCA rate that they were dealing with. And I'm shaking my head. This is too good to be true. Now, I'm not saying the rates were super low. They were still, $500-$600 for an employee only. But the BUCA rates were 1,100, 1,200, 1,300. And so when you see that and you bring this to the employees, and we had one employee cry and said, "Oh my gosh, because of the rate reduction, the plans were better." We said, "I can actually cover my children this year."
Yeah.
And
Yeah.
that's when you're making a difference, where these kids have not had health coverage because she couldn't afford it on the plan they had. And now she can put her kids on the plan. And that makes me feel good, because now I know these kids are going to get taken care of as well.
No, 100%. It's good work that you're doing out there, and you feel it when you're in an open enrollment meeting. And I've experienced this with an employee that comes up to you with tears in their eyes because they would blow through their out of pocket limit every year, couldn't afford it. I mean, we have 100 million people out there with medical debt, which is a ridiculous, staggering number. And so there are many folks out there in this boat. It doesn't have to be that way. It really just starts with plan design. But one point of clarification, we're in the land of the free, and I'm gonna say, if that's true, then Texas is the land of the free on steroids. So what people don't want is to be told what to do. So if they want to go to their traditional doctor, or they have a surgeon that they swear by, and that's what they want, do you stop them from seeing who they want to see?
Yeah, and I think they do. And a comedian I used to know a long time ago, Larry Wingett out of Oklahoma, he talked about, this is America. We have choices. We're not taking away your choice to see who you want to see. We're not telling you have to go here. Now, there are plans that will say, yeah, you have to go certain places. They really want to rein in costs and direct the care. But overall, we give choices, and we may have a network tied in. We may have reference-based pricing. We may have open access. But the main thing is you have a choice. Now, there might be a cost to that. You can choose one way that's free. You can choose the other way that's going to have a cost. An imaging is a really good example. We had someone that had to get a hand X-ray, and they went in and said, "Oh, this goes towards my deductible. It's $450." And I said, "Well, why don't you call in to our advocacy and see what they say?" And the advocacy sent them to the exact same place, same imaging center. They got it for free, and our plan only paid $125.
Wow.
So
Yeah.
we saved $300 to the plan, well, really for the employee, but the employer's like, "Yeah, we'll pay the $125. They're getting the care they need," and the employee was out nothing. But
Well,
it's just having that help.
not to mention that in a traditional hospital setting, that same exam might be 10 times as costly.
Yeah.
10 times. We're not talking about a couple of bucks here, folks. Like, it could be the difference between an $8,000 CAT scan with contrast or an $800 CAT scan with contrast. And as an employer, if you're a CFO listening, just do the math. Think of the numbers. You can pay 80% of 800, or I'm sorry, 100% of 800, or 80% of 8,000. What do you want?
Yeah, exactly.
And at the end of the day, also have your employee or family member of your employee walk away with paying nothing, zero. And so, think about that from a recruiting and retention perspective. It's huge. And so I think, the biggest stigma. So when we're having a conversation like this, this is you and I peer to peer. This is what we do all day long. For other folks that this is not their job, their heads are probably exploding right now. But the reality is, we're not talking about conjecture, right? This is not something that we're dreaming up. This is something that we do every day. Right? So, but an employer needs to kind of take action. And, getting back to, my point at the top, it's still not easy, and it should be. You would think, listening to our conversation, if you're doing anything other than what we're suggesting, you're hemorrhaging money. And, can you put that money, that capital, to better use than giving it to the insurance carrier and your traditional broker, who's the sales force of that insurance carrier? So the Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today.
Yeah, and I think we've had prospects we've talked to, and we showed them huge possible savings, and they're like, "Man, we're minting money. I don't really care. I'm gonna stay where I'm at. But that's because they didn't care about the health insurance. But then if you find another area and say, well, we're talking about $750,000 savings just by making a few simple changes. What else would you want to do with that? And you mentioned the foundation. You mentioned this. Oh, you
Yeah.
haven't matched your employees' 401k for 2 years. Where else can you put that money to benefit your employees or your company? And what can it do elsewhere? You want to build a building. You want to buy a new tractor. And so when you start putting into the, hey, this is not just saving money on the health insurance, but we have to have the big conversation of we're not making the healthcare worse. We're not cheapening your plan. We're not taking away coverage. In fact, in most cases, we're lowering deductibles, lowering copays. We're giving a better plan back, and it just happens to be at a lower cost. And once they recognize it and they see it, they're really jumping on board. And right now, with the way the increases that they're getting it's much easier to have that conversation.
Yeah, and it's so the money is key for sure. I always circle back and I laugh when I hear folks tell me that they're printing money and blah blah blah, and this is budget dust, whatever term they want to use. Because my response to that is, well, are you are sharing this information with your CEO and your leadership team? Because I looked it up and you guys are trading at a 30 times multiple. So if we could save you $5 million and you could essentially take a 30x multiple of that, what are we talking about?
Yep.
It's a little more than $5 million, right? It's $150 million in enterprise value that we're creating for your organization. And what do you think your shareholders would say if they had a vote on this? Because that's what we're talking about. And it's not only 1 year. We're talking about this is
Yeah.
compounded, over time. And so I think that gets lost on a lot of folks, even some of the most savvy CFOs that I speak to. I don't know that they fully kind of appreciate it in the beginning. And I'll tell you what my thought is. I think in the back of everyone's mind, they have to go home and answer to their wife or their significant other and say, we're planning on making a change to our healthcare. And I don't know if you're going to be able to see your OBGYN anymore or your, preferred primary care physician. I swear to you, Dan, this isn't documented anywhere. I don't have any statistics on it, but I promise you, everybody is thinking about that because at the end of the day, everyone's in the same boat. And so they're thinking, oh, why would I want to fuck up our healthcare? It's working fine the way that, I don't like the increases, but, we're kind of good where we are. I don't want to upset the apple cart. And I think that's a big kind of hurdle that needs to be gotten over.
Mhm.
And so my point there though is the money is one side of it, right? So let's dream and say it's 150 million in savings or 10 million in savings or 5 million in savings. Great. What's the other piece of it though? We have a healthcare system that is under constant pressure. And I don't know about where you are, but in New York City where I am, it takes me 6 months or more to get an appointment with my primary care physician. And we have the privilege of paying over 30 to 40,000 a year for our coverage. Something is ass backwards about that, right?
Yep.
So we have the ability to put in as a component of the plan design a direct primary care network. And I'd love to hear what your thoughts are about DPC and that whole movement. And do you think that's going to play a role in the future of healthcare in this country?
Yeah, I think it's starting to get a little more of a role, at least around here. We did do a DPC model. It was a rural town out East Texas, and we had the municipality there as a client. And they really only have one or two doctors in town, and then they have Baylor Scott and White. And we worked with that doctor to do a DPC with that client, and it further reduced their costs. And it made access 7 days a week for the employees, where they could just pop in that office and get anything taken care of. So it was a win for the employees and a win in a cost perspective. But we're working. I have another physician client here in Dallas, downtown Dallas. They have about 9 locations. They just purchased a surgery center as well, and we're working with them to create a DPC model into a kind of a level funded health plan here within the downtown area, because we know they've got 8 offices downtown. You have skyscrapers with tons of companies in there. We can direct all that care to them at a much lower cost. And so we're really going to try to build something out, because I think it is there. I've seen it fail, but I think there's an opportunity there for probably, you know, at least half the population. There are going to be people that are, I'm not changing my doctor and I'm not going to go here. I'm like, but you'll go pretty much anywhere if you happen to be at work and feel sick that day. You'll
Yeah.
walk downstairs 8 floors and go get it taken care of right away. So I think there is a model, but it's going to take, it takes time. We do know, you know, larger companies are starting to put DPCs inside their buildings. I know like the Toyota here in Frisco, I toured their building when they first opened it, and they've got a DPC model in there, a DPC practice in there. Their employees can go there at any point and get taken care of. So the larger corporations are doing it. Now we're trying to bring it down to the smaller ones.
Yeah, no doubt. I mean, on-site clinics and near-site clinics, I think, are, you know, great for large corporations. But what I love about the DPC model is it kind of upends the traditional healthcare system where you're just a cog in a wheel, right? Because most people don't realize it, but direct primary care practices are being gobbled up by private equity, and they're being gobbled up by health systems. And then what happens is you have all of this volume going on, because physicians are paid on the volume of patients they see, and RVUs, their bonus system, relative value units, where they refer patients inside their health system. And so ultimately, when you enter the system, you're kind of in the game, right? To use The Wire, you're in the
Yep.
game at that point. And uh, essentially, when they refer you to the hospital that's affiliated with the orthopedist, and you're getting your major diagnostic exams run through that system, every step of the way, the system is profiting off of you and, you know, the services that they render. And the direct primary care model really breaks you out of that. Now you have a physician where, instead of waiting around in the waiting room of the doctor's office for an hour to 2 hours, them seeing you for 15 minutes and, you know, writing you a script and sending you on your way, they now have you, you know, first of all, you're getting an appointment same day, next day, or within a few days. You're waiting around for 15 minutes. They're spending an hour with you to really kind of assess you, run you through diagnostics. They know your name, they know your family, they know your kids' names. It becomes more of kind of what I think doctors, you know, of yesteryear were all about. They have more general knowledge than I think your traditional, you know, a practitioner, or at least they're exercising that muscle more, because now they're not just seeing you for one kind of slice of specialty, they're handling many different needs. And now if you need a referral, they're outside of that system. And so the whole downstream costs can be much lower. But the key is it's all tied to a better quality care experience. So it's not only about the money, it's also about the quality of care.
Well, it's interesting you said that too. I mean, you look at an HMO here. I mean, technically, it's almost like a direct primary care, because you are picking a provider that is being paid a monthly fee to be your provider. We're
Yep.
doing the same thing, maybe hopefully with a lot more providers. But I had an interesting conversation last year with a provider. My son, we were worried about his growth. He wasn't like sprouting up like his brother did. So doctor said, well, you know, go to this growth specialist. I think it's like adolescent hormone therapy specialist. So we look it up, we go to them, and we pay for the visit. They did a hand X-ray, they did a couple other things, and then as we're leaving, she said, "Oh, that's great. The visit will be here, but starting May 1, we're doing a new pricing model, and we'd like you to sign this sheet." I look at the sheet, and they're no longer doing networks, and they were basically saying, "We are going to have, if you need to come in for therapy and be on our services, the cost is so much per month, a flat membership fee." I said, "Oh, you're doing direct primary care model?" She goes, "Oh my gosh, you're the first person that's ever that recognized that." And she said, "We're tired of the
Right.
billing. We're tired of the insurance companies." And said, "If you want
Yeah.
to come here, it's a direct primary care." So and they said, "We can give the care we want in the time we want, and we don't have to worry about the carrier saying anything."
Yeah. No, it's
And it was
much
really
better.
impressive.
Yeah, I've had the privilege of interviewing a number of direct primary care folks, and I do believe it's a superior model for the patient experience. And ultimately, they're not slaves to their jobs. Physicians are getting burned out, man. They're the traditional caseload for a physician is north of 2,000 patients. When you go to a direct primary care model, it's more in the 400 range. So they're seeing a lot fewer people, and they're able to accomplish more and spend more quality time with them. And so, folks, if you're not familiar with the model, just think of Netflix. That's basically what we're talking about.
Yeah.
You're paying a subscription fee now, and you have access to care. And look, I do think there's something to be said, though, about abusing a system like that, right? Because that'll get us right back to the same mess that we're in. The idea is to pay that subscription and use it when you need it. And I think another conversation for another day is the fact that people are using their health insurance like a Pez dispenser. Like, you can't do that. Like, go to the doctor when you believe you really truly need to see a doctor. And I'm not saying don't go if you believe you need to go, but I think there are a lot of folks that might fall into the hypochondria bucket, and it's just like, just they're accessing the system far too often. What about telemedicine? Are you using that? Is that baked into your plans?
Yeah, so I mean, we started with telehealth when it first started, back in the days when teledoc was just beginning, and really latched onto it. And it was another difficult conversation with employers. Well, hey, we got this great service for you. We've got telehealth. What is this? You want me to do a doctor visit over the phone? And it was a struggle, even all the way up until COVID. And COVID is what I really put it on the map, because suddenly that's the only way you could see a doctor, and that's when everybody started sprouting up. And we have all the different providers now and companies. But we've always put it in our plans, and we really promote it. And we tell people, even when we do open enrollment meetings, this is your first line of defense. It's your first line that you go to. Call telehealth. They're going to tell you right away if they can help you or not. They're going to tell you go to the doctor. They're going to triage you over the phone and tell you what you need to be doing. But it's a free visit 24/7. Why wouldn't you use that? And we see people, they run to the OR or the ER on a Saturday evening at 11 o'clock for, a sore throat.
Right.
And I'm like, well, you just cost yourself $3,000. You cost a plan $8,000 when you could have done it for free, and they could have prescribed, an antiseptic or something over the phone.
Sure.
So it is a cost control, but it's really I say it's a convenience. It's really the convenience of it, and help triage that care. But yeah, we put it in every plan, zero cost. Our employers that have it, we build it into the health plan. If they don't take the health plan, then we try to get them to buy it for every employee.
Yeah.
And we have a drastically reduced cost on our Ovation telehealth. So we really push that out to them.
Well, the idea for folks that aren't in the know is that what Dan is suggesting is this is a component of your health plan that really sits outside of your health plan, right? So the idea is none of this stuff hits your claims. So there is a cost associated with it, but the savings on the flip, if you look at it and it's done right, is phenomenal. It's one of those line items in the healthcare budget that really truly pays for itself, provided that it is done right. But the difference between a scenario like that versus, let's say telehealth that's provided by one of the insurance carriers, is they're treating that like a doctor's visit. So you're still responsible for your copayment. It's still hitting your medical claims. And so now if you use that telehealth in the same way that you would one that sits outside of the box, you're not doing yourself much good there, other than the convenience of, having the ability to call a doctor when your kid is screaming bloody murder at 2 o'clock in the morning on New Year's Eve night, to get some antibiotics prescribed, because that's a classic example for using telehealth when there's no clinics open, nowhere to get any service. But ultimately, you need to work with a strategic advisor that is sitting on your side of the table, advising you with transparency of the best way to bundle all of these things together so that it's delivering maximum impact to your plan and maximum results for your members. And so, I don't think your education here happened overnight, Dan. You've been at this for a little while, right? So and let's face it, I think part of the value that you bring is anybody that comes to you, any prospective client, they're not an experiment, for you. Like you've done this over and over and over again. And I think part of that benefit is, look, I say it all the time. no one has a crystal ball, and you can't know with certainty that there'll never be any problems with a plan. In fact, I could tell you, I could promise you the reverse is true. There's
Yeah.
always going to be something that pops up, but where the rubber meets the road is, am I aligned with the right partners? Do I have a relationship with a fiduciary PBM that is going to do the right thing by the client if the shit hits the fan? Do I have a good relationship with my medical management team? And because stuff will happen, stuff will pop up. And so I don't know about you, but I want to work with folks that are going to be there when the rubber meets the road, when the chips are down, when stuff goes sideways, and they're going to make it right. Because that's where I kind of lose my shit. if
Yeah.
if I have partners that don't step up and do the right thing when I need and the plan needs and everyone is depending upon them to do the right thing, that's when problems arise. And I think the benefit of experience is that you already know that you're working with people that you could check that box. This is not going to be a worry.
Well, it's interesting. We have people, we'll bring in certain vendors that we work with and say, well, here's who we suggest working with. And they're like, what about this one? What about this one? And we've gone through the process where, all right, let's interview them for you. And we'll get you on the phone on a Zoom call and we'll walk through each of them. And we recommend certain ones. And they said, well, why do you recommend them? I said, because I know when something happens, they're going to answer my call. They're going to get it fixed 7 days a week. A lot of them are here in Dallas. I can walk in their office and hit somebody in the head if I have to. But the main thing is, these are people that I trust to take care of you and to get things done when we need it. Versus, hey, use this vendor. Well, I've never worked with them before. If there's problems, I don't know what I'm going to do with that. And then we've had one of those where they forced us to work with somebody that we didn't know, and it was a shit show.
Mm.
And then they went through that year and they said, okay, can we switch to your TPA? I was like, yeah, let's do that.
Yeah.
And it's been great ever since.
Yeah, we do the same thing. And I like the idea of bringing the client along for that ride, not with every single component of the plan, but certainly
Right.
with the TPA, which is a critical, they're kind of the hub and the quarterback of everything that kind of is going on.
The hardest job in the insurance industry.
Yeah, for sure. And so I like to bring the clients along for that ride so that they have a say in the vetting process. And we're not going to put any schleps in for them to interview, but we're going to line up 2 or 3 providers that
Yeah.
we think are appropriate, and then ultimately they're going to make the final decision and call on who their TPA is. So I'm in 100% agreement with you there. So what's next for you? What do you think the future holds? You retiring anytime soon? What's next for Dan LaBroad?
I still got to get another 10 years in me. So right now it's just growth. We're just really focused on bringing in new clients and spreading the message. It's been a lot easier in Texas because of the renewals we're seeing. So people are much more open. And I think the self-funded market here has changed a lot too. So I was looking at stats and just in Texas, and it's kind of similar nationwide. 5, 6 years ago, 10 years ago rather, 23% of employers were in some sort of self-funded plan. We're up 65% now.
Mm.
And so we're seeing that shift where, more and more employers over the last decade are moving into some sort of level funded, self-funded plan. And I think that's one reason that the renewals are getting so much higher. I was talking to my Blue Cross rep. I said, I gave her a BOR, took this group over, and then a month later, I took them away from Blue Cross and put them into one of our plans. And I said, sorry to pull it away. She goes, nah, we're seeing it a lot. And I sent her the rates and the coverage we we're doing. And she said, we're seeing that a lot. And I said, what are they doing about it? She goes, they're trying to figure it out.
Yeah.
But what's happening is when you look at the carriers, and we're seeing these high increases now, all these groups that are leaving and going to some type of self-funded, they're leaving because it's a better deal. Those are a lot of the healthier people as well.
Yeah.
So you're leaving the people that can't do level funded or self-funded. You're staying in the full carrier. So now you have a really dirty pool, and they're that's higher claims, which means they have to get bigger increases to cover the claims. And I think we're just going to see that getting worse and worse.
Yeah. Well, and I don't know where the end of that road is, right? But they've kind of dug themselves into this hole. It's not for my heart doesn't bleed for them, right?
Yeah.
And listen, it's I get it. Like, these are real people with families that are doing their job, right? I think by and large, the folks that work for the insurance carriers are good people. It's not their call. They're doing what they're trained to do. But we're at a tipping point. I think you were probably in the same room that I was when we heard Marshall Allen talk about the healthcare bubble, and it was the first
Mhm.
time that I heard the expression, and I think he nailed it. Like, we are in a bubble, and folks just can't take the increases anymore.
Yep.
And again, getting back to what we said earlier, these high deductible plans that people are strapped with, I don't care if you bolt an HSA on or not, they're functionally uninsured folks.
Yep.
What are we going to do about that? And so I think eventually the carriers will have to iterate, but it's going to take a massive shift. It's not going to happen overnight. This is like the Titanic, to turn that ship. It's not going to happen instantly. I don't know what the event will be, but until then, it's good to know that there are folks out there like you that are fighting the fight, that have real solutions to not only deliver, savings to organizations that desperately need it. And let's face it, I mean, some of the manufacturing companies that we work with, they're riding a razor's edge when it comes to
Mhm.
profit margin. These dollars are super meaningful to them, but it's more than that. It's about their people. It's about being able to give their people quality health care. And believe it or not, that fixes a lot of problems, right? You fix that piece, all of a sudden you're finding it easier to hire people, you're finding it easier to keep people,
Yep.
and it can have a very wonderful effect on an organization. So
Yep.
go ahead, Dan.
I was gonna say, yeah, we're seeing them with hiring people. We're getting that conversation quite a bit now. Is I need a competitive benefits package because the market is so hard. The job market, or not the job market, but the talent pool is shrinking for a lot of areas. And they're like, we need better benefits to attract those people in here. We have to take care of them, and that's where they're asking, what can we do with this, and how can we make this plan better? And that's what we're doing. And on a note of that, we have a prospect working on now. And I said, he's got decent rates with United, I think with Cigna. And I said, well, hopefully we can do some things on the cost a little bit. And he said, I'm not as worried about the cost. Even if it costs a little bit more, I want better benefits.
Hmm.
So they're not all focused on cost. They want they're tired of seeing things stripped away and increased costs to the employees. They want to give better care to their employees, even if it does cost them a few dollars more.
Yeah. Well, the good news for them is you have a solution.
Yep.
For sure. All right, Dan LaBroad, Ovation.
Health and Life Services, ovationlife.com.
Ovationlife.com. Dan LaBroad, founder and CEO. Thank you for sharing your insight. Really appreciate you. Folks, until next time, peace and love. Peace and love. Take care, baby.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.